panel. Thank you to the three of you for being here. Jen, do you mind if I start with you? We've been going from my right to left this morning, so we'll continue with it. I do want to actually say before Jen speaks, I think just after I took office, Councillor McCarthy connected us, and we talked a lot about accessing mental health services across the city and for our residents. And I'm happy that this conversation still continues, and I'm really very happy that you're here with us today.
Thank you.
Thank you.
I really can't thank you enough for your leadership on this, Councillor Sabi-George. All honorable city councillors, esteemed fellow speakers and truth tellers, and concerned residents of Boston, thank you so much for having me here. My name is Jen Erbe Leggett, and I'm a licensed independent clinical social worker. I speak to you today in my capacity as the proud owner of the Leggett Group, a small business which is an outpatient private behavioral health practice in Rosendale, where we serve 350 residents each week with psychotherapy and now psychiatry services. Of note is that while we are a private practice, we contract with a wide array of insurances, and we do have 2 Medicaid contracts and work closely with the community health centers in our neighborhood. I'm also a proud clinical social worker and speak as a volunteer for NASW Massachusetts, a subgroup of which I surveyed for inclusion in today's comments. I also lead a group of perinatal clinicians around Boston who I also surveyed for inclusion in today's comments. I last had the honor of speaking in front of the City Council in May of 2016 when we spoke of mental health and substance use disorder services. I presented concerns about a lack of access for residents and city employees due to the lack of providers who take health insurance in the city. I wish I could say that things have gotten better. In fact, I come reporting the voice of the outpatient providers saying strongly that things have gotten worse in just the areas that you seek to address in your hearing order today. To summarize the comments of my colleagues within NASW and within the group of Boston area perinatal mental health clinicians, we need your help and we need it fast. Our biggest concern, the quickly dwindling number of psychotherapy appointments available across the city, due in large part to settings that previously provided a lot of therapy, making the decision to stop doing so at the numbers previously done. These decisions seem to be driven primarily by the economics of healthcare, and I truly appreciate Dr. Henderson talking about rates earlier, because it's not something a lot of people want to take on. Behavioral health reimbursement rates remain historically low, some not being raised $1 in over 15 years, and more providers leave health insurance panels daily, leaving fewer and fewer appointments for residents seeking care. So while we have high numbers of well-trained and licensed providers in Boston, more and more of them take no insurance or hand select those that pay a close to respectable wage and with the easiest terms of work. As a practitioner who has remained committed to seeing clients from a wide range of socioeconomic levels, this is frustrating, as it further reduces the numbers of seats available for therapy for people. As a compassionate person who is aware of market forces, I'm also sympathetic of the fact that people need to pay their bills as well. Behavioral health treatment has consistently shown conclusive evidence of beneficial effects in decreasing people's suffering and reducing the overall healthcare spend for complex medically and psychiatrically involved patients. Therapy can truly help in powerful ways, often very quickly, and when some people in the city just can't access it, it is truly sickening. Providers I speak with are concerned that there are not enough services for all of the following people: new parents, especially those facing postpartum depression and other perinatal issues, non-English speakers, low-income folks, people who are homeless, people coming out of incarceration, folks with major mental illness, children and teens with anxiety and behavior issues, immigrants, people with bad insurances like Mass Health, people requiring psychiatry, LGBTQI people, people of color who deserve to have someone who looks like them sitting across the room from them, folks with challenges in geography and poor transit, folks who have a difficulty paying higher copays, folks who have difficulty juggling costs of living, especially with kids, and making time for treatment. I'm not sure there's anyone I've left off that list. This group of clinicians wishes for enhanced services in the city to include more representation of difference and language in the provider community, more allied support services in doctors' offices, additional child psych beds, increased training around socially just and competent cross-cultural services, increased support and advocacy for people needing DTA assistance, and a severe increase in affordable housing, issues many of you work on all the time. The specific request that these clinicians are making of the City Council is a strong action in addressing reimbursement rates in Boston so that providers can afford to accept insurance, easier access to high support services that would keep stressed, low-income families housed, and easier access to emergency services. Reimbursement rates really matter. They matter because the historically low rates paid to behavioral health providers lead whole hospital systems to eviscerate their therapy services because it is more profitable to have a higher paid medical specialty or even a nutritionist who has the same master's level of training as me but receives 3 times the compensation from insurance that we behavioral health providers do in that office suite. They matter because people are not able to get psychotherapy in their doctor's offices as they have in the past, which was an important safety net for people with complicated psychiatric histories and who need and deserve extra support and an appointment with no cancellation fee attached if they miss the bus after being kept late at work. I do believe that an alarming and quiet shift has been happening for years now, in which some, not all, large primary care settings are eliminating or reducing their own capacity to deliver mental health services out to the community, as it is a money-losing prospect for their organizations. The problem is, in my mind, isn't that the responsibility of a primary care setting that treats the whole patient, especially in a state that has a clear parity law requiring the same care for a medical or a mental health problem? Shouldn't they be required to retain the capacity to treat the full range of mental health issues of their patients, mostly within their own walls? I started out my own solo practice on Marlborough Street 15 years ago, seeing 27 people per week. I grew that capacity 6 years ago in Rosendale to what is now the Leggett Group, a practice that has grown to have the capacity to see 350 people per week. I just texted my office manager. She reports as of 20 minutes ago that we currently have 4 appointments available in my office. We are pretty full. Last month, we signed a lease to create another 350 appointments per week in progressive Framingham, where the city's leadership is as active and involved as you all are. I have found that the outpatient group practice is a pretty solid business model. We can see a large capacity of people in an outpatient setting that is not attached to a hospital emergency room or MRI machine. We keep costs low, and yet I do struggle to compensate my staff adequately for the very difficult work they do due to low insurance rates, even with the ability a group practice has to possibly gain access to higher rates with some companies. However, we cannot see the sickest patients who should be in a setting with a team of psychiatrists or MDs available and in which they can be rehospitalized easily. Those patients have fewer and fewer options each day. I see a lot of trends and have listened to a lot of people calling with their biggest concerns about their most precious people. And I'm telling you that someone needs to be measuring how many seats there are for therapy in the city and who is cutting the ones that their institution does not want to lose money on. The new smart trend of embedding clinical social workers into primary care settings is wonderful. However, the efficacy of that plan is dependent on having other clinicians within their own settings to refer patients in need to. When this does not happen as a pairing, we see the acuity rising dangerously in our own offices. Cutting psychotherapy services for the sickest people while moving social work clinicians into embedded roles together is not progress, while many people are calling it that. We are seeing the same trend in IOP settings and psych bed settings. And so in the absence of availability for that, very ill people are calling to get a once-a-week therapy appointment in my office. Not the right match for someone who is acutely suicidal and needing round-the-clock care, despite our efforts to include as many people as we can. As a result, I have invested more money in our screening process, making sure that the patients who call in more and more distress are indeed the right match for the skills we have to offer, and to spend the time helping connect them to services that they do need, even if they're not with us. I only see this getting worse and with greater risk for our resident population just trying to get care for their loved ones. The saddest result? It's a tough question to answer, but the call that has most disturbed me in the last year might surprise you. It's not the ED boarding call about a 13-year-old who was boarded for 9 days as there was no psych bed for her across the state. It's not the mom I've spoken to multiple times over the past few years, desperately trying to find compassionate care for her mentally ill, violent, precious son just released from prison. It's not the request from my staff for assistance in rehospitalizing a client who came to us for an intake after being discharged from an inpatient unit without a step-down program in between, requiring 4 hours of staff assistance, for which we get reimbursed for 1.5 hours. It's the single mom with an accent in her voice who called this early October. This mom was calling with an ideal behavioral health request for assistance. Her 7-year-old, previously happy-go-lucky son was suddenly coming home from school with reports of serious behavior choices in school, and she wanted him to get help. She was willing to take the bus anywhere for him, and she'd heard good things about my office and would bring him here from Dorchester. We don't see kids as young as 7 and didn't have any available appointments, so I went through my directory of colleagues and gave her 4 names. I also suggested she call her PCP, which brought the most troubling answer. She had spoken with her PCP's office at her large medical group, and they told her that they could see her son in April for an intake. She was calling in October. When she begged for something sooner, they told her they'd give her a phone screen in February, and that they were booked out in what I know to be their recently reduced small capacity behavioral health system. Half a school year gone for what any clinician knows might be the kind of brief treatment success that may have gotten this young boy back on track in school by solving whatever sudden problem he was having. I told her that if none of my colleagues could see her son, that she should call me back and I'd help her find someone. She thanked me for my help, and asked if I had any other ideas. I suggested that she should call her city councilor, her senator, and perhaps even the attorney general. This mom was shocked that I'd suggest that, but then said, "I can't tell you how much it means to have someone take me seriously. I'm almost crying right now." I'm also going to ask you all to check your assumptions as you listen to this story. Her insurance, Blue Cross Blue Shield. Her healthcare system, not a strange community health center, but a big private one that you likely go to yourself. This is a call that keeps me up at night. I wonder how that boy is doing today and if he got services. It's not good enough, and it's not fair to our city's residents. Thank you for your time, and if I can do anything to help with any of this, please call me.
Thank you, Jen. Thank you very much.